Good day. This video is about meningitis and encephalitis. By the end of this podcast, we should be able to differentiate between meningitis and encephalitis despite their similarities. We start with meningitis. Meningitis is an inflammation of the meninges surrounding the brain and spinal cord. The patient with an infection in the head or neck has an increased risk for meningitis because of the proximity of anatomic structures. The causes of meningitis are bacterial and viral organisms are most often responsible for meningitis, although fungal meningitis and protozoal meningitis can also occur. Viral meningitis is usually self-limiting and the patient has a complete recovery, but bacterial meningitis is potentially life-threatening. Symptoms associated with meningitis include decreased or a change in level of consciousness, disorientation to person, place, and year, changes in motor response. Normal early in the disease process. However, hemiparesis, hemiplegia, and decrease in muscle tone is possible later. Cranial nerve dysfunction, especially in cranial nerves 3, 4, 6, 7, and 8. Memory changes, including attention span changes, which usually shortens, personality and behavior changes, severe headaches, and generalized muscle aches. So CSF is used to help diagnose meningitis, and CSF can cause increased intracranial pressure as a result of blockage of the flow of the cerebrospinal fluid, the change in cerebral blood flow, and thrombus formation. Seizure activity may occur when meningeal inflammation spreads to the cerebral cortex. The effects of aging and meningitis should be noted as well because people who are older than 60 years of age or are immunocompromised or have signs of increased intracranial pressure usually should have a CT scan before obtaining cerebrospinal fluid from a lumbar puncture. To increase patient safety, the most important assessment and the most important interventions for patients with meningitis are accurately monitoring and documenting of their neurologic status, and this includes vital signs and neurovascular checks. Also to observe for early signs and symptoms of increased intracranial pressure. As for infection control, standard precautions are appropriate for most patients with meningitis unless the patient has a bacterial infection that is transmitted by droplets. And individual ages 16 to 21 years have the highest rates of infection from life-threatening Neisseria meningococcal infection. Laboratory assessment of meningitis includes cerebrospinal fluid analysis, CT scan, blood cultures, counter-immunoelectrophoresis, polymerase chain reaction, CBC, and X-rays to determine presence of infection. Also, prioritize care to maintain airway, breathing, circulation. Take vital signs and perform neurologic checks every 4 hours or as required. Perform cranial nerves assessments. Manage pain with drugs and non-medication methods. Perform a vascular assessment. Give medications such as antimicrobials and corticosteroids. Record intaking output carefully. Maintain fluid balance. Make sure that you maintain body weight to identify hypertension early. Provide a private room with a dim light under droplet precautions if necessary. Monitor for increased intracranial pressure. Maintain seizure precautions if necessary. Perform range of motion exercises every 4 hours or as needed. Medication therapy can be everything from broad-spectrum antibiotics, antimicrobials such as antivirals and antifungals, hyperosmolar agents or increased intracranial pressure, as are anticonvulsants and steroids, and steroids are controversial, although they do decrease the inflammation. They encourage infection because of their suppression in the immune system. Lastly is about prophylactic treatment for those who are in close contact with a meningitis-infected patient. Now, we will talk a little bit about encephalitis, and we will review the pathophysiology, causes, preventive measures, physical assessment, drug therapy, and complications. So, encephalitis is an inflammation of the brain tissue and often the surrounding meninges, affecting the cerebrum, the brainstem, and the cerebellum. Unlike in meningitis, this response does not cause exudate or pus formation. Encephalitis is most often caused by a viral agent elsewhere in the body, although bacteria, fungi, or parasites may be involved. Viral encephalitis can be a life-threatening infection that leads to persistent neurologic problems such as learning disabilities, epilepsy, memory loss, and fine motor deficits. In severe cases of encephalitis, the patient may exhibit increased intracranial pressure resulting from cerebral edema, hemorrhage, and necrosis of brain tissue. The typical patient with encephalitis has a high fever and reports nausea, vomiting, and a stiff neck. Other symptoms include changes in mental status, motor dysfunction, focal that is specific, and neurologic deficits, photophobia, joint pain, and headaches. Encephalitis assessments. Herpes zoster may be a cause of encephalitis, and the lesion is clinically manifested by a rash, severe pain, itching, burning, or tingling in the areas innervated by these nerves. Assess level of consciousness is a priority in patients with encephalitis, and lumbar puncture and diagnostic analysis of CSF may be helpful, depending on the patient's condition. For the encephalitis interventions, supportive nursing care and prompt recognition and treatment of increased ICP are essential components of management. Drug therapy is most effective if begun early, before the patient becomes stuporous or comatose. No specific drug therapy is available for infection by arboviruses or enteroviruses. Now we compare encephalitis and meningitis. Encephalitis is the inflammation of the brain, while meningitis is the inflammation of the meninges. The most common cause of both is a virus. Now, cerebral edema, hemorrhage, and necrosis of brain tissue can occur. Also, fever, headache, photophobia, irritability, lethargy, nausea, and vomiting are typical symptoms. Now we come to the nursing diagnosis. For meningitis, this includes ineffective tissue perfusion, hyperthermia, acute pain, disturbed sensory perception, anxiety, deficient knowledge, and risk for injury. As for encephalitis, it includes ineffective cerebral tissue perfusion related to inflammatory processes or increased ICP, risk for injury related to disorientation, seizures, and the unfamiliar environment, altered thought processes related to changes in the level of consciousness, imbalanced nutrition, less than body requirements related to anorexia, fatigue, nausea, and vomiting, and lastly is acute pain related to irritation encephalon. Prognosis. The prognosis for people with encephalitis or meningitis varies. In most cases, people with very mild encephalitis or meningitis can make a full recovery, although the process may be slow. Individuals who experience mild symptoms may recover in 2 to 4 weeks. And that is all about encephalitis and meningitis. Thank you and have a good one.